So in the next 10 minutes, I have to speak, and I'm very clear that as we spoke, sir, it is about first line options, and that's what I'm going to speak. So with the trial of Topaz, do we need to change our way how we are going to treat our metastatic biliary tract cancers or locally recurrent inoperable, so those for a palliative intent? So for me, it has to be chemotherapy alone. And so this is where it all started. That's how for the last decade we have been practicing a doublet chemotherapy with a GEM-CIS, and the ABC2 told us that GEM plus CIS is the standard of care, has been the standard of care, and I feel after the debate, most of us or nearly all of us will tell, okay, it still is the standard of care. So if you look at the OS of 11.7 is something which I want Viraj to very clearly mark out, and that's where the standard is. So you already have the goals very set really up, and it showed a benefit of approximately 3.5 months above standard at that point, that was GEM alone, with hazards of 0.64. Now came the Topaz one, which is the topic of interest, which was published 2 months back, which was presented also this year. And this was looking at, and the professor very rightly put out what it meant and what were the inclusion criteria. But just look at it, that we had to give Durva 1500 milligrams once in 3 weeks with GEM-CIS up to 8 cycles, and then the Durva could go up to 1500 milligrams once in a month. And then this is how it was, and the other arm was a placebo plus GEM-CIS followed by a placebo. So this is what it is, the trial was all about, and the endpoint, as was very rightly pointed out, the primary endpoint was the overall survival. So this is the data, and if you look at it, what I want to mark you is that the hazards ratio is 0.8, but the constant interval, I'm pretty sure, of one or two more patients would have just missed the significance. The range, upper range, is just touching or missing 1. And this is what you have found. This is what the drug Duva as a survival has given to the addition of the GEM-CIS. But this is very interesting, and all of us need to see into this graph, which the professor rightly pointed out, and look at the first 6 months, and look at how the graphs are going each other. Actually, the Duva arm is actually doing bad, and in the first 6 months, which is a chunk of 25% of our patients. Mind you, a quarter patients would be doing worse than the standard of chemotherapy couplet in the first 6 months. And that is something all of us need to remember when we are doing something like a drug like immune checkpoint, especially in India, where this drug can really cut into the pockets and really can burn houses. And that's something very, very important for all of us to remember. Now look at this and contrast to the ABC2, and look at how the graphs really separate out, and the advantage of the doublet versus what the standard was. Very clearly from the day one, you could see the graph separating out. The most interesting comes beyond that, what it is. The objective response, which was the secondary endpoint, the response rate. Just remind you, keep this word of 26%, which is there as an objective response, and 85%, which is there as a disease control, which actually includes the stable disease. And this is where I will come when I come to the next slide. But before that, with this addition of durvalumab with the chemotherapy, look at the median duration of response. And Viraj, this median duration of response was for those patients who had a response. So typically we have seen in other subgroups, especially lung, melanoma, RCC, those who respond, they continue the response, and the median duration of response is way beyond, and we see 2 to 3 times that of the comparator arm. And this is somehow not being seen in this biliary tract tumor. And if you look at it, only after a year, the curves really start separating out, although on the 8th month, the separation starts. But for a good 8 months, they just do not do well enough. And in the first 6 months, the immunotherapy arm actually does worse. Compare this to the ABC2. What I told you is the response rate of 26 with the Durva GEM-CIS and the control rate of 85. And look at it. If you look at the GEM-CIS, you have a response rate of 26% with GEM-CIS in the ABC2. And you have already a stability of disease, which is actually the disease control of around 82%, nearly the same value what you saw in the Topaz one, with the addition of Durva along with the cisplatin and GEM. I just want to take you to the response rate, which also has come from our Indian colleagues in AIMS. And Dr. Sharma's paper put out that GEM plus Oxa The response rates were a staggering 30%, much more than what the Topaz one showed us. And even the GEM and S1 also looked at the data of OS, and also it looked at that this, yes, the survival was around 11.7 months. Now let's come to, is it for all patients? I've told you that I'm not impressed with the data. The OS just is significant. If the two more patients on the other side, I think they would have lost significance. Now let's come to the subgroup analysis, which is how we normally started choosing patients. And this gives us a fair idea which is a good patient for a particular regimen, which is not a good patient. Look at the scores of PDL1 less than 1. And this is approximately 40 to 45% of the patient load. And these patients do not do benefit with the combination, and the lines and the CI are wide enough. Now come to the more interesting fact. The intrahepatic cholangiocarcinoma is something that is known to be immunogenic, that is known to have more of the PDL markers, and that constituted 50% of the patient load. So basically, you run a trial, you load it with patients who are bound to or likely to do better, and they constitute 50% of the patient. We in India deal with more of gallbladder cancers. And if you look at it, they constituted 25%. And Viraj, look at this line, and I'm very sure they are the worst, and they really do not do anything. Even the small little bit, what you see, the bold dot actually sits on the middle of it. So for our Indian patients who are majorly as GCA gallbladders, it is it is totally a waste of the money. For extrahepatic, there is no benefit. For the intrahepatic also, look at it, the confidence interval is 0.98, the upper limit. That's how it is. Now come down to the metastatic disease. Again, it loses significance. So basically, if you have a low PDL1 score, although the PDL1 score do not do very well, but still it's little better. The 40 to 50% patients do bad. For the gallbladder extrahepatic, they do bad. For India, gallbladder is a big problem. That's where they're doing bad. For the metastatic disease to start with, they also do not benefit. Look at comparison to what the APC2 told, and this is how I would like to see a forest plot, because most of the patients invariably will benefit from a doublet rather than the GEM. This is what a forest plot ideals look out. And a professor told about, are we Indians Asians? And all my colleagues here who are from India know that we do not respond to any drug as our friends from the East Asians do, the Taiwan, Japan, Korea. They are something genetically very different. Most of the drugs are very respond extraordinarily differentially in a different way in this population. But look at this from the Topaz. And if you look at the rest of the world, which is approximately half the patient load, they do not benefit statistically significantly in comparison to the doublet chemotherapy. So again, it's a big no, even for a country like India, because I strongly believe we cannot compare ourselves to the data from the East Asians. Now let's come to the other so-called smaller data set, and this is from the GEM nivolumab data. And if you look at it, I just put up one data. The OS sits at exactly 11.8 months, even for the PDL1 positive patient for the combination of the Nivo plus cisplatin and gemcitabine. Basically the same data which you got from ABC2. So can we select this patient who are likely to respond to immune checkpoint? That's the more moot question which I want to answer. If you look at the data, there's very limited scarce data. The tumor mutational burden in this subset, I can tell you the keynote 158, if you look at the tumor mutational burden that came as a publication in Lancet, did not have a single patient from this gallbladder who had or the biliary tract who had a high tumor mutational burden. In that subset, it was 20, more than 10, I think. So if I'm not wrong, the per megabase. In this subset or across the retrospective data in the biliary tract cancer, the high tumor mutational burden do not respond to increased responses to immune checkpoint in this subset of patients. The PDL1 slightly better. We have seen that in Topaz also, they do little better, but not convinced that the betterment is not too good for us to start changing our treatment. Other mutation is something that's very important. That is important because if you look at it, especially cholangio and the other subgroups, especially cholangio, 50% of the patient has something as a mutation. And the data for immune checkpoint with these mutations is lacking. That is something all of us have to remember. And we look at it and look at this cohort K, the MSI high, which I will definitely try to do immunotherapy. This is, if you look at it, even in the second line or third line, and look at the survival for the patient with Pembro, it is 20 months. So I would love to give a chemotherapy and give pembrolizumab for second line, reserve it for the second line if it's MSA high. That's how I would look at it, and that is how I probably will save more money for my patients. And this is what I told you, the number of mutations. And why I'm talking about this mutation, why Professor talked of the mutation is important is the survival is so extraordinarily high. And specifically, if you look at the FGFR2 fusion, the trials, the OS in the multiply failed also is around 17 to 20 months. And that's staggering after failing so many lines. And let us go further. Only known marker which I feel you could try a immune checkpoint in this subgroup of the disease where we were talking biliary tract is MSI high. And if you're doing also that, we need to remember they also have high NTRK fusions. So even I would like to ask the chairperson if he has this report with him of an NTRK fusion there with him and MSI high, and this MSI high have known to have NTRK fusions, although the MSI itself is only 2%. And look at this, what the NTRK inhibitors are doing. They're giving you a median survival or median duration of response of around 20 to 35 months. In contrast, the average response was around 6 to 8 months in the Topaz one. That is the difference what's happening. So I think some more facts to be noted, my last two slides for me. India, because we practice here, we need to talk of our country, our problems. We are stand a very low 99 rank in the income of countries across the world. So we may believe we are a developed, but I'm sorry, we are a little less than the developed nations. And in the global multidimensional poverty index, we come in the last 5 of the world. Still, we need few more years before we can start offering to every patient for 1 month difference in the survival of so-called Topaz 1 trial-like regimens. So some calculations before I end. Durvalumab, I asked the company persons also, 1500 milligrams cost you a staggering 5 lakhs per dose. So Viraj, I made some calculation and it cost a patient 75 lakhs for the drug alone, 4 lakhs something odd for the logistics and the chemotherapy for 8 cycles, and your own professional, I know, is some 5, 6, 10 lakhs probably per annum. If you add that, it comes to 90 lakhs to 1 crore. That's what the patient is going to spend on a regimen like Topaz for 1 year. And if you would want to give it for 2 years, it's a 2 CR problem for the patient. So Viraj, I think you are going to sell a dream after this for the next 10 minutes. So I conclude, is there a rationale? Yes, there's perfectly a rationale of combining chemotherapy to the immune checkpoint. The immunogenicity increases after you do a chemotherapy to a cancer. We have seen that across tumor types. Evidence and its level, at best, I'll concede it's evolving. There is nothing that I need to change my practice. Is it applicable to all? Not at all. I'm pretty clear, Viraj. I think we are not going into every patient that lands to an OPD. Toxicity, this is one good thing that's I put it in green. A toxicity addition of the Topaz, the Durva to the chemotherapy did not do much to a toxicity. And cost benefit analysis, I don't think anyone should even bother to do this. With 1 month median OS difference in the survival, I think it is definitely a no-brainer that it is not going to be cost benefit to the patient. So take home, should wait for further data. The median OS for approximately a 1 month difference, at least to me, is not worth spending the money for the Durva. Toxicity data looks good. That's where the main thing comes through for this Topaz 1 like regimen. What I would do probably, I may be jumping the line. I would consider an NGS at least for the cholangio subgroup of patients upfront, if ideally for all the patients, and then would like to plan accordingly. So this is Viraj. You're going to see him for the next 10 minutes, I know. He is going to sell the dream. That also I'm very sure. But I'm pretty sure all the audience here, don't try Viraj and sell no dreams, because all of them are wide awake. And I'm pretty sure they are not going to sell into your dream selling. Thank you, Viraj. Thank you, sirs. Thank you, everyone. And I will leave the stage open for Viraj to start selling his so-called dreams of a crore of rupees.